and everything for you,
Sure.
Dr. Charles, and do a quick land acknowledgement, and then we can get things on the road here.
Sounds good.
All right. I will get going as of right now then. When people join, they can just come into the room as they join. Today we have a special guest, Dr. Lesley Charles from the University of Alberta. She's going to be giving us a presentation on memory loss. And me and Steph have been talking throughout the last couple of months, and this is something that you guys had requested to be a topic in an upcoming meeting, so we put it together for you. I'll do a quick land acknowledgement to get things going, and then we'll do a roundtable, and I will let Dr. Charles do her presentation. So, in the spirit of our journey to promote reconciliation, we would like to honor the truth of shared history and acknowledge the many nations who have lived and cared for these lands for generations. I'd like to acknowledge that I'm joining from Treaty 6 land, the traditional meeting ground and gathering place, traveling route of the Cree, Nakota, Saulteaux, Sioux, and the homeland of the Métis Nation. We acknowledge all of the many First Nations and Métis and Inuit whose footsteps have marked these lands for centuries. We are grateful for the traditional knowledge keepers and elders who are still with us today and those who have gone before us. So those of you that don't know me, I'm Chris. I have been running this group for about a year, and I want to apologize for last week's meeting with the discrepancy in time change to Ontario. So if you need to yell at me, feel free to private message me here, or I think most of you have my email. But I guess we'll do a quick roundtable of what are some people looking forward to for school starting, actually. So it could be that the kids are gone for a little while. It could be that you get a little bit of a vacation, whatever the case may be. So I will start with Angie. Is there anything you're looking forward to for September coming up here, dear? You're muted if you're trying to talk, Angie. Okay, we'll go to the next person. Ben, are you available to speak? Oh, mic's not working. Okay, no problem, Ben. That works just fine. Okay, well, I'll just share something that I'm looking forward to for September then. Um, I will be moving into a new house and the kids will be back at school, so it'll give me a little bit of time to do some renovations that are needed. And if anyone else has anything, feel free to pipe up or I will hand it over to Dr. Charles.
All right, thanks. Thanks for inviting me. So yeah, we're going to talk about memory loss. And nothing to disclose in terms of any conflicts in giving this presentation. So what we'll talk about today are changes in cognition with age. We'll specifically go over the DSM-5 criteria. With any cognitive change, you always want to be looking at ruling out delirium, depression, and reversible causes of dementia. We'll talk about some of the types of dementia that are out there, as well as treatments. So with cognition, everybody's memory is going to change as they get older. Particularly, people are going to notice their short-term memory is not as good as it used to be. With mild cognitive impairment, they again may complain about the short-term memory, of course. They may also notice that they have word-finding difficulties as a common one. And forgetting names of people. They'll be things you might hear about, but they are not going to have any change in their function. And we'll go over a little bit more about that next. With dementia, they are going to have problems in two different areas of cognition. So that could be memory itself, it could be speech, it could be something that we call praxis, recognition, executive functioning, or visuospatial. Any of those two in any of those areas, but there will also be functional loss. So to cross that line into dementia, it has to be impacting their function. And then as always, we want to rule out delirium, depression, and any medications that could be causing these changes. So in terms of those different areas, things you might ask patients about or they might tell you about, is that short-term memory. This will often lead to repetition, and that will change throughout the disease trajectory. At one point it might be repeating things from week to week, and then it becomes every day. And then, of course, it can become within minutes that they're asking the same thing again. When's so-and-so coming, or when's this appointment? It can be recalling names. Again, it'll be people who are really seen in the first instances. So maybe like ex-colleagues, distant family members, and then it's going to progress to those who they're seeing on a regular basis. Losing items, and then recalling details. So I'll often ask about if there's a family gathering, can they remember why everybody got together, who was there, what happened, things like that. But it can be details about anything. The second area there can be problems is speech. So the biggest one you're going to hear about word finding. Just can't quite, string their sentences together because they're not finding the right words. They have to pivot and switch. Overall, they may be decreased fluency and decreased spontaneous speech. They're just not as talkative as they used to be. And then there may be issues with reading, writing, or actual comprehension. With recognition, it can be three different things. It can be people. So not that they don't remember their names, which they may have an issue with too, but they just don't recognize them at all. It may be places. I will often ask about the common ones, going to the grocery store, going to the bank, anywhere they go on a regular basis, are they still recognizing where they're going? And then things. And so in extreme examples, it can be that somebody will use something in the wrong way. So maybe they use a toothbrush to brush their hair. Praxis, in terms of history, we will ask about having any troubles using the appliances around the home. And it does have to be appliances that they used to be able to use, because you will hear stories about, oh, well, we got a new TV and they've never been able to use that. And that is obviously in part due to changes in technology, but also short-term memory if it's something new. When it's an actual praxis issue, it's an appliance that they did used to use. Common ones are things like the TV remote, the microwave, increasingly computers. People used to be able to use them to email family members, go online, do their online banking, and as memory issues develop, they're not able to do that. Executive functioning are the most complex things we do. So that could be things like planning a vacation, a big, dinner like at Thanksgiving or Christmas. But, not a lot of elderly are not necessarily doing all of this kind of thing. And so what I look for everyday executive functioning are two of the most complex functions that we do: managing finances and managing medications. How are they doing with those? And then the last area is visual spatial orientation. And that can be mixing up days and nights. It can be getting lost, issues with navigation. So we talked about how the real distinction, people may have issues with their memory that would still be classed as normal aging. It may be the mild cognitive impairment. When it crosses to dementia is when it begins to affect function. And it's going to affect the most complex ones, the IADL's instrumental activities of daily living first. So that's the things like shopping, cooking, cleaning, finances, and medications. Specifically, you want to find out with shopping, do they make a list? Is that always something that they've done? Are they getting everything on the list, or are they having to go back to the store because they've forgotten items? Are they buying stuff that then when they get home, they realize they already had it? And again, whether this is a change for them, because obviously if it's been a long-standing pattern for them, then it may not be part of a cognitive process. With cooking, are they still able to cook the meals that they used to cook? And this one can be difficult because people simplify cooking for many reasons: physical limitations. Maybe they're now living alone and they don't want to cook like they used to. So again, just trying to get at the underlying, if cooking has changed, why did it change? Cleaning, are they keeping the house like they used to? Again, can be affected by physical limitations. Yard work, if they're doing it, can they still do it? Driving is a big one, especially very early on. We would like to have history from an unbiased caregiver who has actually been a passenger in the car with them within the last few months, and whether they have any issues with the patient's driving. Specifically, we'll also, of course, ask about things like accidents and tickets. And again, if there are any of those, are they different to what they're usual? Because somebody who's always got a speeding ticket every month for the last 10 years, it's not necessarily going to be related to their cognition. Finances is a big one. Who pays the bills? Who sorts the mail as it comes in? And works out what needs to be done. Are they set up on an auto deposit? If so, who did that? Are there any ones specifically that aren't on automatic deposit so that you can check in whether those ones are being paid and if there have been any bills that have been missed? Medications, how they're managing those, whether they're managing them from vials, a dosette, a bubble pack, and whether there are any missed medications. Generally speaking, you're not going to diagnose a dementia initially affecting basic activities of daily living, unless, it's kind of like a missed dementia, so it's at a more moderate to severe stage at diagnosis. The other times it can happen, you will sometimes see, is that, one partner, I would say most often a wife, has actually taken on and done all of these IADLs. Maybe if the husband was the main breadwinner and it's just always been their pattern that she's done everything. And so then it makes it really difficult because strictly speaking, you can't then diagnose the dementia until they lose one of their BADLs, which is a much more moderate to severe dementia than when it first affects the instrumental activities of daily living. So the basic activities of daily living are, of course, the things like washing, dressing, bathing, if they're able to feed themselves, not as in terms of food preparation, but actually being able to feed themselves, toileting, and then transfers and ambulation. And it is a small group, so if anybody has any questions as we go, please do jump in if something isn't making sense. So when they revised the DSM-5 criteria, they replaced the term dementia and mild cognitive impairment with major and minor neurocognitive disorder. As you can imagine, those terms are not heavily used. They're longer. If you try discussing those with patients, they do not know what they mean. So I still very much use the terms dementia and mild cognitive impairment. So in terms of the minor neurocognitive disorder, they diagnose it as evidence of modest cognitive decline from the previous level of where they've been, and this can come from the patient, it can come from information from a caregiver or a clinician. There may be decline in neurocognitive performance and so on. It's some kind of cognitive testing that you're doing. However, just like we've already mentioned, that these deficits are not sufficient to interfere with their actual functioning. So they're still functioning normally, doing the activities they always did, as always, not due to a delirium or a depression. For the major neurocognitive disorder, again, evidence of substantial cognitive performance. Again, this information can be from patient, caregiver, clinician, or some kind of cognitive testing, but this time it is interfering with their function. Again, not due to delirium or depression, and this is, of course, what we would term as dementia. So how common is it? Basically, it doubles as you go up every 10 years. 8% at age 65, going up to 16 at 75, going up a little bit further than doubling at 35%. And I always tell this when I see patients in clinic who are 90, it's 50-50. So, patients can obviously be very traumatized being diagnosed with a dementia, but I tell them, well, it's really the luck of the draw. 50% of the time, somebody your age is going to have dementia. So these are our types of dementia. Patients will often ask what's the difference between Alzheimer's and dementia. So we always tell them, well, dementia is an umbrella term for patients with cognitive issues, but then there can be different types of that which are actually causing their dementia. Alzheimer's being the most common type, slowly gradual progressive dementia that comes on typically over months to years and more commonly years. Vascular, we have the old criteria whereby it was the multi-infarct dementia. Somebody would have a stroke and they would have a step down in cognition. Then they would be fine until the next stroke if there is another one, and they would step down again. It's not really like that. Particularly people may have more smaller vessel disease as opposed to an actual infarct. And then there's a lot of heavily overlap. In patients with Alzheimer's, up to 50% of them will have vascular changes if you do an actual autopsy. So mixed is those who have, you find maybe lacunas on their CT scanning, but they have a typical course like Alzheimer's. They might have a strong family history of what's been diagnosed as Alzheimer's. Then we have Lewy body dementia, and we are going to talk a bit more about these in Parkinson's. Frontotemporal dementia, it could be a brain injury, it could be substance abuse. So looking at the four major types, we can see the different amounts that they represent. And again, this is not strictly true. We actually think that probably there's a lot more mixed dementia than what's showing in this pie chart. But it has their Alzheimer's as the most prevalent. And then the vascular, bearing in mind that there's going to be some crossover with mixed. Then Lewy body, it has it there as 12%. It's actually really interesting when they do autopsies after people have passed away. They find Lewy bodies in 25% of patients, but yet we don't diagnose anywhere near that amount of Lewy body dementia in clinic. And then, of course, frontotemporal dementia is quite rare. So what are the warning signs that people may complain about, or family members may notice in patients? And so that's that memory loss affecting day-to-day function. We've talked about that quite a bit. It may be difficulty performing familiar tasks, so particularly things like in those instrumental activities of daily living, language or speech problems, disorientation to time or where they are. It may be that they first notice just poor judgment, making decisions that family don't think they would have made of before. Problems with abstract thought and then losing items is a big thing people complain about. The other things that may come up, mood and behavior, and these symptoms, especially mood, may start earlier, behavior is usually later. Personality changes, and then just that loss of initiative is a huge one that people complain about, that apathy. They just don't want to do anything, can't get them to do anything. I really like this diagram. It's an old one, but it kind of shows what to expect where. And so before there even is a cognitive decline, there may be mood issues. We do know that people with depression have increased risks of dementia, but at the same time, particularly early on, when people still have insight into their memory issues, they are often obviously very troubled by what's going on, and there can be depression that precedes a true actual diagnosis of dementia. Then we see the cognitive decline, which will start off as the mild cognitive impairment first, going on to then an actual dementia. And with that, it's going to impact the function, and we're going to see that loss of function. Usually later on, so usually we're not seeing it in mild dementias, but obviously it can sometimes occur, is when we're going to see those behavioral and psychological symptoms of dementia that can occur. And then last, and we don't tend to see these patients in clinic very much. Often these are patients that are going to be more seen in long-term care, is when it actually begins to impact people's motor skills. And obviously in severe dementias, end-stage dementia, patients can become bedbound. So I've mentioned a few times here, we always want to rule out delirium. Delirium is different from dementia in that this is a very acute change, something that's come on suddenly and it fluctuates. There will be problems with attention. So, if you go in to speak with them, their mind's going to wander. They're not going to really follow the conversation that you're having with them. There may be disorganized thinking, and there may also be change in level of consciousness. I'm just going to look in the chat here because I think I see maybe whether somebody is having some questions. Oh, cranky, yes. And that level of consciousness might be that they're more irritable, aggressive, or it may be a hypoactive delirium, just where they're more sleepy. So it can be either of those. It's very, very common. 30% at least, if not more, of those admitted to hospital will suffer some level of delirium. We do often look for a medical cause when there is a delirium, the big ones being infections. If somebody develops a UTI or comes in with a pneumonia, it can be medication changes, medication withdrawal, including alcohol. There may be some metabolic abnormalities, obviously very common when people are in hospital, hypokalemia. It may be that there is hypoxia, and there may be some neurological event like a stroke. And so often part of a delirium workup is doing that CT just to make sure that nothing neurological has happened. 25% of the time we don't find a cause. There are also things that predispose somebody to becoming delirious. And one of the big ones, of course, the biggest ones, is having a cognitive diagnosis in the first place. So whether it's mild cognitive impairment or dementia, somebody comes into hospital, they are much more likely to get delirious. Other ones are sensory deficits. So when people have hearing or visual impairment, when they're dehydrated, immobile, all the kinds of things that can happen when people are in hospital. Depression, very, very common in seniors, often underdiagnosed. It's not always that typical low mood as the main symptom, so it can be quite hard to diagnose, but it is still very treatable. There are non-medication options, although they're not always readily available, although a lot of PCNs do now have access to mental health therapists. It is very prone to relapse. The big reversible causes of dementia would be things like thyroid, B12 deficiency. Not typically going to cause a full-blown dementia, but if somebody's just having some early cognitive changes, it may be that by addressing these things, hypercalcemia, which obviously is usually quite a worrisome thing in itself, normal pressure hydrocephalus. So if we do suspect that, that's definitely one of our indications for doing a CT. Most patients with cognitive issues do get a CT these days, but that would definitely be one of the ones we would be CTing. Depression, like a pseudo dementia, and then of course if they're on different medications that can be causing cognitive issues. So I did say we'd talk about the different types of dementia. So Alzheimer's, of course, is the one that comes on very gradually, most often over years. It's mainly going to affect short-term memory first. Maybe they're repetitive and executive functioning. There may well be a family history. Vascular dementia, we talked about that multi-infarct dementia, the stepwise progression, although it may more just be ischemia of smaller vessels. And so you may not hear that history of an actual stroke and then a cognitive change. Mixed dementias are those where there is Alzheimer's and cerebrovascular disease. And like I said, it is increasingly felt that this is a much larger group of dementias than what were previously thought. Patients are often likely to have both Alzheimer's and vascular dementia co-pathologies, and it can be difficult to distinguish, at this point in time, our diagnoses are clinical based on the history, and we basically decide which one we think it is. That things are going to change in the future, but that's the way we diagnose now. And so, of course, we're not always correct. And then, like we mentioned earlier, if we actually do autopsies, then in Alzheimer patients, or who are felt to be Alzheimer's, 34 to 50% of the time they will have vascular pathology. Frontotemporal dementia is that one that's fairly uncommon. It's a relatively new disease. It was first only discussed from 1986 onwards and used to be called Pick's disease. This is the one which really presents with behavioral issues early. They may be disinhibition, um, loss of social awareness. They may be neglecting, just, hygiene poor. Um, and then they may also just be that inertia and impulsivity. They often see things very black and white, and they often may be associated aphasias, so problems with speech, is another thing that you might hear about. Lewy body dementia is probably makes up about 5% or so, but although um, in what we terms of we diagnose, although it is felt to be much more prevalent, so maybe we're just not very good at diagnosing it. But they do have different pathologies on autopsy. Um, as the name suggests, they have Lewy bodies in their brain, as opposed to the plaques and tangles that are seen in Alzheimer's. And so they do have a quite complicated diagnostic criteria, which may be why we're not very good at diagnosing it. But they talk about if it's most likely probable Lewy body dementia if there are two core features or one core and one suggestive. Possible would be if there's only one core or one or more suggestive. And in terms of those core features, those are the things it fluctuates, visual hallucinations. So on first looking at it, it can seem like it may be like an actual delirium. But of course, in terms of how long it's been going on, the timelines are going to help distinguish between a delirium and an actual Lewy body dementia. The other big feature is Parkinson's symptoms. And then suggestive features, where if you have one of those and a core, you're still going to be probable Lewy body. If there's only one or two suggestive features, then it would just be possible, would be this history of REM sleep disorder, neuroleptic sensitivity, whereby they really get snowed for days with just small amounts of antipsychotics. And then if you actually have a scan, like a SPECT or a PET scan that shows a low dopamine. All right. Any questions so far before we go on to the treatment? Just checking the chat again.
I wanted to ask Dr. Charles, what kind of role does diet and nutrition play in dementia? And is there a type of dementia that's more prevalent with low nutrition and diet and bad diet?
So, in terms of risk factors for dementia, some of the biggest risk factors are cardiovascular risk factors. So those are all impacted by poor diet and nutrition, whether it's diabetes, cholesterol, blood pressure, any of those things, and they can all be impacted by diet. So people can actually improve their cognitive symptoms. When we first see people with mild cognitive impairment, our biggest aims of counseling them are on management of cardiovascular risk factors and on being active. So both physically active, socially active, because we know that social isolation increases dementia, as well as cognitively active. So anything that they like to do, they even say just reading the newspaper each day stimulates the brain and can help maintain cognition. And then the other big thing we will address is hearing, because there's such a big association between low hearing, loss of hearing, and dementia. So we'll definitely talk about all of those things. Because at this point in time, we don't have any treatments to offer people with mild cognitive impairment. So we go through all of that advice with them. And there are lots of different mild cognitive impairment sessions. The Glenrose, of course, is the biggest one that you can send patients to. They do that mostly online now since COVID. Some of the PCNs at different times have had their own groups as well that they refer patients with mild cognitive impairment, and I think they just go through in more detail all of that information. So in terms of treatment, this is what we have right now. Our mainstay are the cholinesterase inhibitors. There's 3 of them, and they all act to increase acetylcholine in the brain. Because part of the working theory is that patients with true Alzheimer's don't have enough of acetylcholine. Aricept has more studies in actual Alzheimer's dementia, Reminol in vascular dementias, and Exelon in Parkinson's and Lewy body. But they can be used interchangeably, and as somebody progresses on one, I will often discuss with them the options of switching to another one just to try and buy more time, versus adding in memantine. Memantine is typically second line and an add-in to cholinesterase inhibitors. Cholinesterase inhibitors are covered by Blue Cross as long as patients meet the criteria on one of the cognitive tests. Memantine, unfortunately, is not. Never has been covered by Blue Cross. So that's why I'll always discuss with patients and see whether they want to try a switch to another cholinesterase inhibitor as they progress, or whether they have the funds and would like to add in memantine. It acts in a different way. So that's why it's an add-on. It's working to decrease dopamine in the brain. Sorry, not dopamine, glutamate in the brain, which is an inhibitor in the brain. It costs $150 a month. When the studies were first done, usually because it's an add-on, so it's a more moderate to severe dementia, they showed that caregivers got back an hour a day in terms of have less help with activities of daily living, less redirection in terms of behaviors. And so, people would say, is 1 hour worth $5 to you in terms of the cost of these medications? They're all looking to stabilize. Some patients may show a little bit of an improvement on cholinesterase inhibitors. It's usually about a third of patients. But typically, we are just looking for them to stay stable on them. And so that's what we're following for. Are they still stable? If they're not stable and they're progressing, then we have to look at our other options. But this is all about to change. Because there are new treatments that are emerging for specifically Alzheimer's dementia. So this is only going to be for those, and that's why things are also going to change in terms of how we make this diagnosis. Right now, it's a clinical diagnosis based on the history. But if these new treatments become available, then we're going to have a very specific diagnosis so that we can decide who are the best patients for these treatments. So these new treatments are anti-amyloid monoclonal antibodies. So they're looking at reducing those plaques in the brain. There's 2 of them that are being already under review with Health Canada, lecanemab and donanemab. And the other new thing is these treatments are both for mild cognitive impairment and dementia. And they've shown improvements in stabilization and decreased progression in both those groups. Whereas cholinesterase inhibitors were tried in those patients with mild cognitive impairment, but they didn't change the rate at which they transformed to a dementia. And so they were always kept as a treatment just for when the patient did actually have a dementia. It is kind of a similar story to cholinesterase inhibitors. These are not the magical cure that obviously people would like. They are going to slow progression, but they're not actually going to improve things and stop the disease altogether. The other big issue with these medications is that they have more risks than the cholinesterase inhibitors. The risks are of developing swelling in the brain and bleeds in the brain. And these are called amyloid-related imaging abnormalities. And you might, as these treatments go into practice here, the term ARIA is the thing that's being watched for. So it's going to change practice incredibly when these medications do become available. And I do think they will. They're both already available in the States and are being used. Because already, like when we do comprehensive geriatric assessment, we spend 2 to 3 hours doing this whole assessment with the patient. But now it's going to be a much bigger counseling session. We're going to have to talk about those benefits and, tempering expectations. It's not a cure. It is really just slowing the progression, versus the harms, which is the swelling and the bleeds in the brain. It's a much more involved treatment process. It's not just a tablet they have to take once a day. There's a twice monthly infusion for lecanemab, or monthly for donanemab. So, they've got to go to an infusion center. These are IV infusions. There's a lot of workup that has to be done for this. Number one being there has to be amyloid confirmation. And so that means either finding amyloid on a PET scan, which we do not have these amyloid PETs available at this point in time. So the other option is to find the amyloid on CSF testing. So obviously an invasive test to do a lumbar puncture. And so that's going to be the first thing. The other thing is we have to do, and so this is why, if we do then meet the criteria for Alzheimer dementia, then, like I say, we're going to know they have Alzheimer's now, not just based on the history. There has to be ApoE4 genotyping. ApoE4 is the allele that increases the risk of Alzheimer's, and why you often hear about Alzheimer's running in families. But those who have that genotype have an increased risk of the amyloid-relating imaging abnormalities. So again, you've got to have that discussion with patients who are positive for ApoE4, that they are going to be at increased risk of the swelling and the bleeds in the brain. And then there's a lot of monitoring, and that monitoring right now is because of this area. You've got to have a baseline MRI. There can't be too much vascular change on that MRI. We talked about how up to 50% of Alzheimer patients may have vascular pathology. On autopsy, how much of it is going to be noted on MRI. It may not be as specific at picking it up. But what we do know from the States, like thinking about who comes to our clinic with a cognitive issue, even if we feel by history that they may be an Alzheimer's patient, it's probably only going to be about 10 to 15% of them who will meet this criteria for actually being able to take one of the monoclonal antibodies. But it's a huge thing that's coming, and it's going to be a huge change to practice, not just in terms of how we make the diagnosis, how we treat and how we monitor, but even just in terms of getting people onto this pathway. How do we do that in a timely manner? Because right now, the waiting list for geriatric clinic is 9 months. So we're going to have a different triaging system to try and identify these patients. So in terms of our summary of management, and this is kind of going back to what we're doing right now, because we don't have these monoclonal antibodies right now. Right now, it's our comprehensive geriatric assessment where we look at cognitive history, neurobehavioral changes, which can be the depression, it can be the behavioral and psychological symptoms of dementia, because obviously those overlap with the cognition. We're looking at function because that defines whether it's dementia or not. We do lab testing, the physical exam, and then most patients would have a CT. Our medications are mainly the cholinesterase inhibitors, although there is a memantine option, particularly for those patients who are able to fund it. We look specifically at function to see are there any deficits and things that the patient needs support with. So often looking at home care, always family can support them. We look at mood, behavior, psychosis, and safety. With safety, we're thinking about driving, the stove safety. Are they wandering? There are stove timers now. Wandering registry, patients can wear bracelets, kind of giving families all of that advice. And then obviously any concerns with driving. With driving, the only patients that would, once they have a cognitive diagnosis, would be mild cognitive impairment or mild dementia. If they have dropped 2 IADLs, those instrumental activities of daily living, or 1 basic activity of daily living, which just makes common sense. If you can't do something like get dressed, wash, then you should not be driving a car. But similarly, if you have dropped 2 of your IADLs, 2 things that you used to be able to do, big ones would be, somebody else had to take over the finances, somebody else is doing the medications. Again, you should not be driving a car. We talk about medical legal issues. So these patients obviously are going to have an increased risk of needing an agent under the Personal Directives Act or an attorney under the Enduring Powers of Attorney Act. So we definitely encourage all the patients we see in clinic to set up a personal directive and enduring power of attorney. We look at disposition. Can they continue to live where they're still living, or do they need a higher level of care? And then caregiver burden, and what can we do to reduce that? And that was the end of the presentation. Normally I put some questions at the end, but I must have forgotten today. Any questions?
I don't know if it's necessarily a question, Lesley, but when it comes to the driving portion of dementia, I find in my community, it's tough to bring that up to some people, especially because then it just starts a whole wave of other things. I know a few gentlemen in particular, once they start getting their license taken away, then they feel useless and then they just sit at home and it starts the whole social isolation and it
Oh,
just makes
yeah, yeah. And of course,
it's
it's
a
so
mess
overlapping anyway, with the cognitive issues and the apathy. Some of it's already there before they even get the license taken away, but it just escalates.
for sure. Yeah, for sure. It's a tough thing to navigate sometimes for people because there's so many unknowns and so many different variables towards dementia. It's a tough thing to navigate sometimes.
Yeah, definitely.
Yeah.
Definitely.
Does anyone have anything else for Dr. Charles?
Yeah, I get a question in regards to, like you said, losing licenses. I deal with a lot of clientele who get pretty angry or upset. So I'm looking for some tools or resources to help turn that back around to continue to help find them the positives in their life. Because I find sometimes blame is on the doctor, on the spouse, on me, and it's getting them to understand that's not where it's coming from. So any ideas on how to help change that around for them because they struggle, obviously, right?
Yeah, it's really difficult. Like in the past, we have had driver cessation programs, but there aren't any at the moment.
Okay.
And so often it will be about number one, counseling, whether it's just friends and family, counseling them and talking to them and trying to help them, or whether actually actual formal psychological counseling, because it can be a huge thing. And then the other thing is making sure that they are aware of all the different options.
Yeah.
So that it isn't seen as much of a, oh my gosh, what am I going to do now? I don't have any other option for getting around. There are actually lots of different options, although again, you're working with seniors who may not necessarily want to entertain them.
Correct.
Like these days with Uber, if they were able to use a smartphone, then they can have very easy, accessible options for still getting around.
Some can use smartphones, but very limited, right? Like we put just certain apps on, so it's very easy for them to run because anything else I find is very overwhelming depending on where they are in their journey, right? With Alzheimer's or dementia. So I try to keep it very limited for them because the more confusion, the more frustration, the more anger,
Yes.
right? So yeah.
Yeah. I think, increasingly as seniors are using more things like smartphones before they develop cognitive impairment, because I do see many patients who can still use it. And so I think it will be helpful and in a way to mitigate the issue of driving, because obviously there are other sources. I do actually have a whole presentation on driving, if it would be helpful to give at another point in time, and it goes through all the different resources. Um, Somebody was asking about those infusions. They're not available in Canada yet. Health Canada is still reviewing them, but they've been available. For a couple of years, lecanemab has been available in the States, and about a year, donanemab has. So we are expecting to hear about these new medications soon.
Ben just had a quick thing in the chat as well, Lesley. He just wanted
Mhm,
to thank you very much. He's a little bit newer to social work, he said, and he just said
mhm.
the information was very helpful.
Oh, no problem at all. No problem. Great. Well, thank you all for attending today. And if anybody has any questions after that they'd forgotten to ask, my email is very simple. It's just lcharles like my name that's printed there, at ualberta.ca.
Dr. Charles, would you be open to sharing those slides with me in case people want them
Absolutely.
as well? Okay,
Yep, I
perfect.
will
Yeah.
send them on to you.
Thank you very much. Yeah, just send me an email with those slides and I can get them out to the participants as well. Thank you so much for that.
No problem. Have a good day, everyone.
You too. Thank you very much, Dr. Charles. Take care.
Thanks. Bye.